Obviously, all of us at the moment are surviving on the hard work and dedication of our healthcare workers, right? Who are trying to keep many of us alive, particularly the old and infirm and elderly. And it's kind of rather shameful in many respects that healthcare is being purposely targeted by cyber attackers from around the world, and we're having to face not only a deluge of sick and dying people in our health system, but also a massive influx of attacks. A number of hospitals have been hit by ransomware and by other forms of extortion since February, and there's been pretty much an exponential rise over normal numbers. I was going to say it was a 4x rise over last year's numbers, but that was back in February, and I think the numbers since then have got even worse. So let me start, if I may, by introducing myself. For those of you who don't know me, I'm Richard Staynings. I'm Chief Security Strategist with Cylera. We're a biomedical startup that looks at the risk and asset management of medical devices and healthcare IoT devices, which we'll come back to in our discussions later today. But I'm also involved in HIMSS and AHIS and CHIME and a number of other healthcare organizations, and have spent much of the last 25 or 30 years focused primarily upon the healthcare industry and how we go about securing it. So what I'd like to start, in the interest of time, is to go down the list and to invite each of my esteemed panelists here today to say a few words about themselves, their company, and then we'll get into some of the questions that we prepared. BJ, do you want to start us off today?
Good morning. You hear me okay?
Yep, perfect.
Okay. Yeah, I'm a retired federal law enforcement career, did 26 years with the ATF in the United States, and then went into healthcare corporate security for about 4.5 years. Now I do private consultancy and teach at Arizona State University. We had discussed some of the specific physical environments of the acute care and the remote care setting in healthcare being generally violent, in addition to the fact that there are large concentrations of populace, and so you have the normal criminality that takes place on these different campuses and whatnot. But I'm glad to be here.
Great, thank you. Brett, do you want to say a few words?
Absolutely. Brett Cattell, Director of Systems at Robin Healthcare, and really big responsibility of mine is to integrating systems into each other. So from security, compliance, and things like that. So have had a lot of excitement with the whole COVID piece, and so everybody going to telemedicine and all of these other things, and be able to immediately plug in a lot of extra stuff. So been exciting times, that's for sure, especially like as you were mentioning for healthcare.
Oh yeah, absolutely. Yeah. Eric, did Eric join us today? Eric Smith?
Well, so Eric can't make it, but I've been talking with Frederick, so I'm looking for him. So if Frederick is in the audience, sometimes people join with names that are not their own. So if he is, then please let me know. But otherwise, please continue, and I'll find him.
Yeah. Okay. All right. Great. So, well, thanks very much for joining us here today. So, I want to start by, talking about some of the nuances of healthcare, the healthcare industry, compared to, financial services or manufacturing or retail or any of the other industries that we could mention here. What is it that's unique about healthcare? And what is it that's unique about healthcare security? And Brett, since you're the provider here, perhaps you could start us off by talking about some of the challenges that you see with your provider hat on, and some of the things that you've had to deal with, particularly in light of the current COVID crisis.
Gotcha. So just in general of some of the security challenges and things like that is that everybody, all of the different vendors and things like that we've been either working with, or the different clinics and hospitals and things like that, everybody has their own sense of what is secure. And so some people have complete, lockdown to even be able to authenticate into the wireless and have it tied in with Active Directory, and have gone through there and whitelisting IP addresses, MAC addresses, and all of those type of things. And so that to the other ones like, oh yeah, everybody uses the the open corporate network and we give that to our guests. We have those type of things, and so we either have a guest or a corporate wireless, and you kind of fall into two of those type of things, and they don't have that. So it's a wide variety from that standpoint in terms of trying to get things integrated. And I think that's where probably a lot of the pieces of the puzzle are missing, is that not everybody has gone through and fully adopted or understood and fully comprehended what security really means, and are going through and understanding that, implementing it. And then in terms of some of the changes and things like that, I think, I don't know how much people have been following some of the healthcare news, but a lot of the integrations and the need for going to telehealth and the need of adopting new systems, they actually suspended HIPAA rules and things like that to be able to get around. There was such a need to be able to adopt so many of these things just to keep the lights on for clinics, because they suspended all of the elective surgeries and such a shortage of the surgical and provider equipment. There's been a lot of hospitals that don't have the revenues that they were expecting, and they have, essentially it's about 10-to-1 of administrative tasks to every provider. And so having to go through and change all of those things and be able to adapt to lose a lot of those revenue streams that they've been able to rely on. And then in addition to that, try to plug in and completely come up with a new workflow that they needed to do, and with security and all those other things. So they did throw the security rules out, and those are going to be coming back into effect here very soon. But I think that's probably through all of that chaos, is probably one of some of the biggest areas that I think there's so much opportunity for outside providers to come in at a much lower cost, because already there's not a whole lot of revenues that are coming in, to be able to do that and be able to get some assistance in those areas.
Right. BJ, what are you seeing in terms of, the change in the regulatory space, albeit temporary, and the change in delivery methods for healthcare?
I would speak to the fact that, as I mentioned, these acute care settings in particular, in the United States, the number one most assaulted employee in the United States is the female RN or nurse, second only by the behavioral tech. And so these healthcare settings are very physically violent, and then you have a lot of crime and graft that happens in a large campus environment. But even as the systems, obviously you have amalgamation of healthcare systems where they're buying up, which might have been fractionalized delivery systems for like urgent cares and some of the non-acute care day off surgery centers and those kind of things. They all become one system. They have the immediately lack of efficiency of having disparate systems and processes and all of that. And I think that the biggest gap at the moment is the fact that there's so much stagnant data out there that's not being utilized in terms of intelligence that could provide a warning or a threat for people that have had behavioral issues before, or conduct issues, or those kind of things because of, say, a HIPAA wall, or just the lack of efficiencies of sharing information. So there's a lot of information out there that if it was analyzed in the passive, say with AI, for example, it might provide the physical security forces or elements with a heads up about people that are potentially a threat that are coming into the small facility of, say, 5 employees, or the giant facility of 5,000 employees. But that's a missing data set that could be exploited to provide safety to patients, to visitors, to vendors, to students, to anybody who hits this environment. And it's unnecessary, in my opinion, a gap, because it's information that's there to be easily analyzed and to provide a great heads up for the purposes of being proactive to prevent violence there and or crime in that manner.
But it's always a balance, isn't it, between privacy and public good, and I think that's one thing that has really challenged all healthcare systems around the world with the current COVID crisis, particularly in terms of tracking systems. that are being, I just read this morning that France is going live with its COVID tracking system, and the UK is following very shortly thereafter. So you can look forward to that, Phelan. There's this balance between privacy and security and and the public good. How do we deal with that?
I would offer that, it's a responsibility of anybody that's in a leadership position, whether security, risk mitigation, or all these things, where we're really supposed to be the sheepdogs in these areas, even if it's in the cyber area, that our presentation to leadership and people that are impacted by perception of an organization or how a board is going to think of all those kind of things. I would say it's a required acumen to be able to present a realistic, pragmatic solution without scaring people to death, without expecting this complete surveillance type of thing, which is will never happen in the United States. But the balance with a solution using simple tools to at least have a sight picture on things that are avoidable. And so I think that's probably the one solution, is having the leadership and the communication ability to make this effective.
Right, so I want to come back to one of your previous points and open this up to Brad at the same time. You mentioned about data sets and small providers. Obviously, there's a massive consolidation that's going on across the healthcare industry in the United States, particularly in rural areas like New Mexico, or predominantly rural areas like New Mexico, where those small community clinics are, and standalone physician, general practitioners, primary care physicians are being sucked into community health systems, are being drawn into university-based health systems, where those data sets can be amalgamated and be made much more useful. Is there a role here for the managed service provider to specialize in healthcare, to develop some of the skill sets, to manage controlled data sets, protected data, protected health information data, for example, in such a way that makes it more beneficial to the small providers and beneficial to the community at the same time?
I'm going to direct that one to Brett.
Oh, gotcha. So I definitely think that there are some opportunities to be able to assist with that. The tough part is those larger organizations that are consuming all of the smaller practices and those type of things in those situations. Typically, they already have teams that are already be able to do that understand their own data sets to be able to port a lot of those things over. So from that standpoint, I don't know if there's a whole lot of, if I was to sit there and put my own MSSP hat on and try to go through and do that, I think I would, I don't know how fast that's really going to be happening. I would really focus on more of supporting those companies, and they're going to be, especially with the crisis and a lot of the things that have come down, they're really looking at their books. I think they're really looking at their spends. Yes, that is one parachute of being able, yes, I can give it up and be able to go with the larger ones. I think now is a good time to be able to say, look, you don't have to go through and give everything up and be able to join any of those larger practices and things like that you can't survive on your own. Here's some good cost-effective ways that we can go through and secure your data. We can be your subject matter experts in security, and we do understand your EMR and your health system. And then as well as being able to understand all of the different devices. There's a lot of the IoT things. There's tons of items within that healthcare system that be able to plug in, that have data feeds that need to come into the EMR system, the electronic medical record system. And that's essentially their ERP system. That is their goal. And so being able to understand that, understanding the data flows of coming in from all of those IoTs. A lot of times there's data flows out because they're subcontracting MRI readings and imaging readings. And so to be able to do cost savings, they can be able to sub out some of those specialized services, and those are just sending data feeds out, data feeds in. So if there is a way to be able to build a practice around understanding those type of things, securing those, and be able to speak to that from those small to medium practices of anywhere from 1 to 20 providers, I think that is really the sweet spot in the area of opportunity for the MSSPs to be able to say, okay, I can target for healthcare in this MSSP space, and the ones that are surviving and not getting, not joining forces with some of these larger institutions.
I want to come back to one thing that you mentioned there, and that is cost, right? You know, when I've had these conversations with CEOs and CIOs, CISOs of healthcare systems, particularly the smaller ones, about, you know, you should join forces, you should combine, you know, threat intelligence feeds through the healthcare ISEC, or you should look at, you know, other forms of support, because you plainly don't have the skill sets in your team right now, nor are you in a position that you can afford to attract and retain the type of detailed skill sets that are needed to, you know, proactively threat hunt across your network, you know, to look and thwart cyber attacks while they're in process, right? To understand that you're under attack before the ransomware note shows up on your system. How do MSSPs manage to price their services at a price point that is affordable to, you know, the five doctor GP practice, right? Or the critical access health system in a rural community?
Yeah. From that standpoint, in terms of the pricing, I have, from being into the industry more as a consulting, I haven't gone through and done a lot of the pricing aspect, but if anything, I would go through and kind of take a look and see what kind of fractional, I would take it kind of from a fractional engineering type of perspective and say, if I was to hire it and do all of that stuff inside, tools, people, assets that I need to be able to do that, how would I go about identifying how much that costs and be able to go through and say, look, I'm only able to, you know, it's a fifth of it or half of it of what you would be able to do and to supply those needs. And go that route from that, and try to build the practices from that standpoint.
Right. Yeah, absolutely. I want to
open up to,
sorry, go ahead, Brett.
I was just going to say, because right now, I mean, the providers and the doctors and the hospitals, they're really looking at their budgets very, very tightly right now. And there has been a lot of, you know, layoffs just from all of the administrative functions. I mean, so they're really been looking at consolidating from that standpoint. And so if you can go through and be able to say, look, they're already in that mindset of fractionalizing, you know, how can we join our insurance validation team with our billing and our prior auth, and like they always had individual people for that. And so they've been combining those internally. So what kind of, in that same mindset, I think they're already in that frame of mind to be able to have those discussions. Whereas before, they were doing so many, you know, surgeries, a lot of those high volume, high dollar amount items. So the costs were not as high, and it wasn't really that much of a big thing that they were able to look at. And now I think there's a really good opportunity where they understand that is a great feasible model for them.
Yeah, and I think, you know, you raise another good point there, and that is really around the changing paradigm of healthcare delivery, right? From payment by procedure to, you know, payment by results type of model. And as you point out, a lot of smaller hospitals are empty at the moment, right? Or physician clinics are empty, specialist clinics are empty at the moment because everyone's giving all of these hospitals and healthcare providers a very wide berth because they don't want to be anywhere near these, you know, the sick or the potentially sick, right? So how do we look at our healthcare delivery model for the future? I'm going to open this up to BJ, since Brett's been kind of leading the piece here. What does our healthcare model of the future look like, BJ? How do we reconcile, you know, the need for nearby rural healthcare providers in our community with the fact that there's a big consolidation and, you know, otherwise a closure of those small facilities, which could potentially result in someone suffering a heart attack having to be driven 90 miles to the nearest hospital?
Yeah, and unfortunately, I think that is the trend. I mean, when you hear the conversations in leadership about where it's going, they have to find the efficiencies and profitability even for a nonprofit system. And, you know, these large acute care centers with the operating costs, and then the one model is to combine all services under one roof. And then now this sort of disparate rule and service delivery I don't know what the answer is for that is. And the trend is, I think the market is going to determine what happens. And then, you know, obviously in the United States too, we have an unresolved healthcare issue in general, because you're bouncing between managed insurance care that's paying certain rates and people paying out of pocket, and then the attempt by, you know, our legislature to create healthcare support in terms of provided insurance in a social way, and so because all that stuff is not fixed, and so the market, it's very hard, I would say very difficult for them to see where the profitability or even survivability is going to be with these changes, for sure.
Yeah, would you not agree that we're in the middle of a health policy crisis in the United States, right? And also a healthcare crisis, and I'm not, you know, putting aside the whole pandemic management and everything else. 71 cents in every dollar that all of us spend on healthcare, our entire aggregate healthcare spend, goes towards the treatment of critical diseases, you know, high blood pressure, diabetes, stroke, heart attack, right? All of these types of things. If we look at the growing government side of healthcare, whether it's Medicare, Medicaid, or Indian Health Services, that figure is even higher because that population is generally sicker and a bigger consumer of multiple chronic diseases, right? In Medicaid, 88 cents in the dollar is spent on the treatment of chronic disease. And in Medicare for the elderly, it's up in the 90%. You know, we're spending an awful lot of money treating diseases that really we should be looking at from a public health perspective and catching when people are younger, right? Diet and exercise and sugar intake and what have you. Is there not a mismatch there between the market-led health system that we have been in since, you know, 1946 when all the GIs came home from the wars in Asia and Europe, and the, you know, the bigger need here to manage and keep our population healthy and safe from disease, whether it's chronic disease or communicable diseases?
I'm stepping out of my laneway in this topic area for sure, but I can, from anecdotal personal experience, if you go to one pharmacy and your drug offering is $500 out of pocket, but by getting online and getting an app, you pay $12 at the grocery store for the same thing, it doesn't seem like that's sustainable as a system in any way whatsoever. So yes, I agree with your conclusion. I wanted to say one thing back to the security threat issue in terms of communication to leadership, and especially in these changes, and when these systems are trying to prioritize where the funds are going to go for the variety of challenges they have, is, you know, to assume it's also the responsibility of anybody in leadership when communicating these things, to assume nothing, that the audience has any idea what you're talking about. And it's almost like Coach Lombardi, right, for the first Super Bowl team, you know, he started every football camp with saying, gentlemen, this is a football. So we have to approach that type of communication with a zero assumption in the delivery. And of course, obviously in the community, or who we're talking with today, and everybody that's so strong in their fields here, we all probably very much so assume that people have any concept of what the hell we're talking about, and they have none. And so I'd say it's the onus on anybody that's trying to create change to assume nothing and to communicate with education mindset. Right.
I would agree with you. And I think that's the case with most people at the top of the political pile in most countries, quite frankly. There are challenges as to what they actually know and understand. Coming back to, you know, so we've got a healthcare policy, a public health issue in the United States, but we've also got a skills gap issue, right? I spend a lot of my day in hospitals, not recently, not since February anyway, but walking through hospitals, dealing with MDs and nursing and other clinical staff, as well as, you know, the administration and the C-suite. And there is a constant grapple here to attain and retract the right number of nurses that you need to run your hospital. There is also an issue around attaining and retracting IT staff and security staff. And as the technologies in healthcare are changing, we're moving more from a palliative care model of nursing, the Florence Nightingale model of healthcare, to put it in one term, to the highly invasive, highly automated, highly digital nature of healthcare that we're seeing in the 21st century. Brett, you mentioned earlier about the rise in medical devices and healthcare IoT, right, which is really outnumbered traditional IT servers, workstations, cows, wows, desktops, whatever you want to call them, across healthcare, and they're growing at 20% per annum. How do hospitals build up the capabilities that they need in order to manage this morass of network connected devices? And is it possible to do that without some level of managed expertise on board? Brett, perhaps you could start us on that.
Yeah, so I definitely think it's capable of doing it in-house, but the fact of the matter is that they're too busy with everything else that's going on to effectively be able to put those controls in place to have the successful of rolling out, new devices or new vendor got brought on. They're bringing all their devices, be able to do that. And so they're so busy with the existing workflows and stuff that I think those are great ideas or great areas of having experts come in that have the time, that have the diligence, that have that focus of making sure we do need to put it on a separate VLAN or be able to create a devices VLAN and have some foresight of the future to be able to put some architecture and some controls in place to be able to do that. And not just setting that and say, hey, we got it nice and secured from the entry point, but being able to build in those proactive checks and the monitoring pieces that will be able to create that tie into their ticketing system or their alert management or their SIM system, that they would be able to get those alerts and notifications, because they're not going to be checking on those things. And I think that's probably one of the biggest things that get forgotten, and especially probably the number one if it's in-house, because they're moving on to the next biggest thing. But that's where, having those expertise and that focus is like, look, we're going to spend the time to do it right. And whereas a lot of times in the in-house people. And so you mentioned, the new IoT devices and all those things that are coming in, but now just even the telehealth that's been kind of thrusted upon doctors that have not been ever had to do telehealth services ever. And so I can't tell you how many teaching people how to use Zoom, doctors how to use Zoom and how to admit a patient from a waiting room and all of that stuff. And I think you could probably relate to some of those things of learning how to get those that technology integrated.
I think we could do a whole hour session just on telehealth and digitalization, quite frankly. So
even those type of technologies of being able to go through and say, here's how to properly secure it, here's how to be able to get access here, and now you have a bunch of uneducated end users that are trying to be able to access these systems, and then where's that data go, and be able to go through and provide those levels of service and advisement, I think is extremely crucial right now, because there's a lot of people with their heads spinning.
Yeah, there's definitely a big gap between current capabilities that I see, on the ground in healthcare and those that, are being offered by, traditional MSSPs in the space. Is there a need, though, for a healthcare-specific MSSP, or a need for the larger MSSPs that are kind of encroaching in this space to develop, siloed capabilities, or not necessarily siloed, but vertical capabilities around healthcare, so that they have the knowledge of asset management in an IoT-connected environment, so that they can manage the OT aspects of a healthcare network, like HVAC and elevators and other critical building management systems that are on their networks and are exposed at the same time as the traditional IT endpoints that most of them specialize in. Is there really a need for a healthcare MSSP here?
BJ, did you want to jump in?
In terms of, integration for any of this, again, for me, it falls back to, it just seems almost unethical to have information sitting there that it's not being used for the purposes of, the sales point would be profitability and sustainability, but also the fact that there's data that's sitting there stagnant potentially that could help somebody from being victimized, that could help an organization from becoming subject to litigation, that could prevent a number of negative things. And so anything in these systems that provide both the profitability, the efficiency, and a way to utilize the information for those ancillary but critical purposes would be the objective.
Right. So I think we need, you know, we've drawn a few conclusions from this. One is that there needs to be much better data management. There needs to be a revision of regulatory frameworks, not just the temporary, you know, collapse of a lot of the HIPAA rules and regulations that we've seen to facilitate telehealth and, you know, the current crisis healthcare delivery, but also that there's some healthcare policy issues and public health issues that you know, we as a nation need to be looking at, and particularly as that affects rural areas, you know, around, you know, the Southwest states, for example. So we've got a lot of challenges in front of us here. And I think we're pretty close to out of time. So I just want to do a quick round to Brett, a few final words before we pass over to our next session.
I was just going to mention, yeah, absolutely. And so I do agree that there is definitely a need for healthcare specialized MSSP, just one that the language and the conversations and the industry, they want to be able to feel heard, not just from a regulatory and understanding all of those regulations, which overlap across all of the ISO standards. So HIPAA, you know, has so many ties that overlay over ISO. The EMR system has so many ties and overlays to manufacturing and ERP systems. And so all of that stuff, I think, translates very well. So it's not too far of a stretch. It's learning the vocabulary, learning that piece, and through those, I think that builds the trust. And so I think that there is very much an important need for that vertical for that, but I think the existing skills translate very well. So I don't think it's too far of a gap for MSSPs to be able to make that transition and be able to add that dash line item or products that we specialize in for that.
But it needs to be priced appropriately.
Yes, review your pricing models. Important.
Yeah.
And don't be afraid to change it as you need to.
It's all about meeting the needs of the market, right? So I think that's, you know, one thing that BJ mentioned earlier on in our conversation today. So with that, I'd like to thank you both for your excellent contributions and participation here today, and hand it back to Fulham for our next session.